So first thing, somebody just came up to me and said, is there anything new in GERD? GERD, or gastroesophageal reflux disease, is probably the most common disorder that I see as a gastroenterologist, an adult gastroenterologist. And probably if you ask Dr. Kahana, he would tell you he sees it in infants and newborn. And gastroesophageal reflux disease means simply that the valve between your esophagus and your stomach weakens. So the food and the, I don't know why I'm getting that feedback stuff. The food and the hydrochloric acid of the stomach will then come up into the esophagus. And if it comes up too much, can actually burn your vocal cords. So I see a lot of patients who present with hoarseness, who present with a chronic cough. Excuse mine.
Sorry. Is that better?
This is better. Yeah, this is the one I started using. I'm keeping this one. So what is new? Coming out probably in the next year or two will be a circular, envision this, a circular magnet that would go on the lower portion of your esophagus. And this magnet would keep the food in your stomach. And when the food bolus would come down the esophagus, this magnet would open by the pressure of the food. And then the food would go into the stomach and the magnet would close. So that's currently being patented as a way to treat severe reflux. Number two, where we just had the FDA approve radiofrequency ablation for Barrett's esophagus. Barrett's esophagus was a disease described by Norman Barrett in the early 50s, where the stomach lining grows up into the esophagus to try to protect you from the acid that's coming up into the esophagus. But we didn't realize until the years passed that Barrett's lining is a precancerous condition. So I again wanted to emphasize to everyone that if you're having excessive long-term reflux, you should see your gastroenterologist for at least one endoscopy to look at your esophagus and see whether you have Barrett's lining. It usually will not form after that initial procedure if you remain on proton pump inhibitor medications, such as Nexium or Acifex or Protonix. The Barrett's usually stabilizes. So what has the FDA done? They've approved something called radiofrequency ablation. This is a balloon that goes down to the Barrett's area, and you burn it. You actually burn it for a fraction of a second, and that Barrett's lining then is replaced by normal lining. This is a major, major breakthrough. Right now, the FDA approved it for Barrett's with precancer, which means if you just have Barrett's lining, that means the stomach lining that has grown up in the esophagus, and it does not have precancer, you are not eligible for radiofrequency ablation. But think of what a tremendous accomplishment this is if someone has Barrett's lining and they're in that unlucky 2% per year that turns into cancer, that you would not, previously you would have to have your esophagus removed. Now you would undergo a 10-minute procedure and you would burn that cancer and that lining, and it would be replaced by normal lining, which is a tremendous breakthrough. And the pediatricians know this very well, that up until Dr. Barrett described this, in fact, Barrett thought it was congenital, and he thought that the Barrett's lining was just a an anomaly that occurred in about the 12th or 13th week of gestation, because the entire esophagus was stomach lining up until then, and then it turns into esophageal lining. And he felt, and like a lot of other people, that the Barrett's lining just meant that it didn't go through a normal process to make it all normal lining or squamous lining. So that's really the hottest thing in Barrett's that I wanted to say. Everyone knows about Helicobacter. I've spoken about that to you before. If you've had an ulcer, you want to be checked for this bacteria, since now the numbers come down a little bit. About 50 to 60% of people with ulcer disease have the associated bacteria Helicobacter. And it varies among where you come from. In Asia, 50 to 60% of Asian people will have Helicobacter. Here in the United States, it's only about 8 to 10%. Another major breakthrough. This year, we have released 2 drugs for hepatitis C, pills. These pills, which one is called Telaprevir, one is Bocephevir. They're both fighting now for who's going to take over the market. These pills, or protease inhibitors, will be combined with the standard treatment for hepatitis C. The reason these drugs had to be invented was that hepatitis C in the United States was only 40 to 45% treatable. That means getting rid of the virus, being cured of the virus. These 2 new drugs double the cure rate. Double the cure rate. I just put 2 people on it for the first time. It doubles the cure rate. The cure rates now, we can honestly say to you, are 80 to 90% for hepatitis C. There's 150 million people affected with hepatitis C. This is worldwide. So this is a tremendous breakthrough in liver disease. The other major breakthrough I wanted to talk about is the inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Does anyone have a relative or with either ulcerative colitis or Crohn's disease themselves? A smattering of hands. A disease that has a double peak in the very, very young, maybe up to teenage years. Then it kind of peters out, and then there's another bump that people didn't realize in people over 60. So people shouldn't be surprised when the doctor makes a diagnosis of ulcerative colitis in somebody who's 65 or 70. There's a double peak. Well, right now the thinking with this disease is we're going to these biologic agents very, very early in the treatment of the diseases. For instance, I'll give you one example is Remicade or Infliximab. These are drugs that inhibit the immune response, and we're now going to them very quickly. We're not going through this high doses of steroids. We're not going through all the other steps to get up there. That's called down up. We're getting very aggressive in putting people on these biologic agents. We used to have only one that was given intravenously over an hour, and now we have the intravenous one plus 2 that are given by yourself, and they are fabulous. I've seen them heal fistulae. I've seen them put people into remission who are on the way to the operating room to have their colon removed. These drugs can be spectacular for ulcerative colitis and Crohn's disease. Another hot item, I can't even get to my subject. The other hot item is a disease called eosinophilic esophagitis, seen that people used to think it was just a kid's disease. Now adult gastroenterologists are seeing it all the time. It's when these little eosinophils, they're white cells, so to speak, eosinophils. You see them in allergic people. They go into the esophagus and they cause difficulty in swallowing. So we used to have patients who would come to us with difficulty in swallowing. We would look at them, find nothing, probably think to ourselves that they were crazy, and we didn't know that this disease occurred in adults, and it can only be diagnosed by a biopsy. And then you get a certain amount of eosinophils. And this disease is treated in different ways. In fact, at the DDW, which is the major meeting of all the GI guys, somebody presented an article on an exclusion diet where virtually 100% of patients were put into remission. All the eosinophils went away and they could swallow perfectly by manipulating their diet. So let me move on now. Those are the hottest things in GI at the moment. I'm going to move on now to diverticulosis, which is my topic for today. I would say that close to 100% of people over the age of 60 have diverticulosis. Diverticulosis are little out pockets, little pockets that occur throughout the colon. Usually they're on the left side in the sigmoid colon. The reason they form there is because that's the most narrow portion of your colon, and it therefore generates the highest pressure. And as you know, the colon is constantly going through contractions. So if it's constantly contracting, it's building up pressure in certain areas, and these little out pockets form where the blood vessels come into the colon. That's a little weak area. So you get these little pockets. Now, what happens with these little pockets? Most of the time, nothing. I mean, I do a lot of colonoscopy and see a lot of diverticulosis, and I'll come out and talk to the people in the room and say, well, how much abdominal pain are you having? Or how much constipation? Nothing, doc. So most of it remains no symptoms from these pockets. But about 10% of people get terrible complications from diverticulitis. You have to make that distinction. Diverticulosis are just these pockets. Diverticulitis occurs when one of the pockets explodes into the wall of the colon, and that particular area gets infected. That's diverticulitis. And we try to treat that, and we're usually successful with antibiotics. If you're very sick, we'd have to put you in the hospital. The symptoms are severe pain on the left side. That's why they call it left-sided appendicitis. Number 2, you get a fever, and you're doubled over with pain. That's severe diverticulitis. IV antibiotics. Diagnostic test of choice would be a CAT scan. Clearly shows diverticulitis. Does diverticulosis cause symptoms? Maybe. I've seen a couple of patients who have intermittent pain over the left side. And you work them up, and all you find is diverticulosis. It may be that the diverticulosis and that high pressure on the left side is what's causing them their pain. Number 2, first is diverticulitis. Number 2, these little pockets can bleed. This is something you all must be aware of. When you have painless bleeding and the blood is like a Cabernet or a Merlot, that color, and you have no pain, I can guarantee you that that's diverticuli bleeding. If you have pain, severe abdominal pain, and then start bleeding, that's not diverticulosis. That's probably a lack of blood supply to the colon. We call that ischemic colitis. Very common in people over the age of 60. It's like a heart attack of the colon. A little tiny blood vessel closes off. The body responds by severe abdominal pain, and within a couple of hours you're passing blood. That's ischemic colitis. So painless bleeding, go to the bathroom, all of a sudden you're pouring out maroon-colored bowel movements, you get to the emergency room, right to Torrance Memorial Emergency Room, because you can really, really bleed heavily from diverticulosis. If you get pain and fever, and it's not that severe, I would get to your doctor as soon as possible. Just walk in and say, I'm very sick, I think I have diverticulitis. They'll see you, we hope. That's why we built the urgent care center. Because after 5 o'clock, you can't get a doctor. Have you noticed how medicine has changed? You notice now that your doctor doesn't admit you to the hospital anymore? There are no primary care physicians, except maybe 2 on the staff of Torrance Memorial and Little Company that admit their own patients. They're all admitted by hospitalists. So I, of course, from the old school, they'll always call my office and say, are you coming to see me? I'll go and see them. I'll say, well, who's your doctor? And they'll have absolutely no idea who their doctor is, because the hospitalists change on a daily basis. This is one of the things I'm trying to resolve. I want continuity of care. I want a discharge summary sent to the primary doctor so they know you were at least in the hospital and have your history. What we're trying to do as an aside in THIPA is to make it very smooth. Have the hospitalist call the discharge planner. The discharge planner will set up an appointment at our senior assessment, senior center. We'll go over all of your medicines with you, and then you'll go back to your primary care doctor. I want it to be a smooth transition from the hospital back into care with your primary care physician. It's 3 o'clock, but I'll just say a couple of words on colon cancer again. The virtual colonoscopy, which everybody thought was going to be so hot, that was the CAT scan of the colon with the recreation. Well, it turns out it just never really has panned out to be a great screening test. Medicare has elected not to reimburse for virtual colonoscopy. That virtual colonoscopy, I hope, is when you put air into the colon, you pump it in, and then you take a CAT scan both on your back and on your stomach. And it can pick up polyps that are very big, but it cannot pick up small polyps. So the only time we do the virtual colonoscopy now is when I can't get all the way around for some reason. Diverticulosis, 9 out of 10 times, that's the reason why I can't get around. I'll go in and it'll be so narrow from frequent bouts of infection that I can't get through, and I certainly don't want to push my way through, because you'll be waking up in the operating room saying, I didn't start here. What am I doing in the operating room? So we don't want that to ever happen. So that's when you use virtual colonoscopy, when it's an incomplete examination.